Uh, Sorry that you cannot continue class in the morning. We are having a long case discussion on male breast cancer. The case will be presented by Dr. Shaurya Kumar Satra, who is a third-year resident at Arcane Position, University of Medical Sciences. And today our moderator will be Professor Chintamani from New Delhi. Shaurya, you can share your screen, present up to history. Wait, let's Chintamani sir have some points discussion on history and then proceed to examination, and then you go finally for discussion. Okay, Shaurya, you can share your screen and start.
Good evening, respected teachers. Today we'll be presenting a case. My patient, Mr. X, 60-year-old gentleman, carpenter by profession from Kharagpur, West Bengal, presented with lump in right breast for last 4 months and ulcer in the same breast for last 1 month. Patient was asymptomatic 4 months back when he suddenly noticed a small lump in the central region in right breast, initially of approximately 1 × 1 centimeter, insidious in onset and rapidly growing, and has increased to a present size of approximately 4 × 4 centimeter. There is an ulcer over the lump involving the right nipple areola area for the last 1 month with occasional serous discharge. The lump was initially painless, but for last 1 month, it was associated with intermittent mild dull-aching pain, which is non-radiating in nature and relieves on medication. There is no history of nipple discharge, no history of any swelling or lump in the opposite breast or any axilla, no history of significant weight loss or anorexia, and there is no history suggestive of any distant metastasis. On past history, patient is not a known case of diabetes or hypertension. There is no history of TB or TB contact, no history of radiation exposure, no history of any steroid intake or long-term medicinal intake, no history of any trauma to right breast or scrotum, no past surgical history. On personal history, patient takes mixed diet, married, have 2 children, bowel bladder habits are normal, sleep appetite are normal, no known allergies to any drug or food, no known addiction. On family history, there is no history of any BRCA-related malignancy in family like breast, ovary, prostate, pancreas, or colorectal carcinomas. Summarizing my history, 60-year-old gentleman with insidious onset, rapidly growing lump in right breast for last 4 months, initially 1 × 1 centimeter to presently 4 × 4 centimeter size, with an ulcer over the lump involving right nipple areola area, with an intermittent dull-aching pain and occasional serous discharge for 1 month without any history suggestive of distant metastasis.
Good history.
Okay.
And you probably had a relatively easier case to present the history of. So please don't get it wrong, because these are cases where there's not much in the history that deviates from your usual style, right? So if you go back into the first slide and second, I'll probably tell you something. This is perfect. There's no problem. Lump in the right breast and ulceration subsequently. So we understand. So what a good student should do, I'll just make it better for you. First slide, please. Go back. Go back. Yeah. Lump in the right breast, 4 months, and ulceration for the last 1 month. So we understand that you're talking about the same problem. Is ulceration in isolation or it's a part of the lump? So you would basically be making it simpler for yourself and also for the examiner. It is correct even this way. I'm just making a good thing better. Next slide. Now, this was very nicely done, actually. And you covered up certain aspects which I was thinking, otherwise I'll ask you. Because usually in breast being small, most of the lumps or the lesions would be confined to the central zone. There's no quadrant there because it's not a quadrangle. So central zone. So that is fine. And nipple areola complex getting involved and everything else falls into place. Next slide. Now, when you write no history of this, no history of that, no history of lump, no history of that, blah, 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 it looks very, very monotonous. You're not the first one doing it. It happens almost every day, even at my place. So there is no history of nipple discharge, lump in the contralateral breast or axilla, significant weight loss or anorexia, chest pain, cuffs, or any other features suggestive of distant metastasis, which you took I think hematuria is usually not a presentation unless you have got something very specific in mind. So when you're talking about no history of hematuria, is there something else in your mind?
Uh, Sir, actually, in
Elderly
case of
gentleman, anything else to be thought of?
You see, the
El-
point is what just now Professor Shah suggested. I would be very much interested in rather than the laundry list, if you make them look relevant, like you mentioned about abdominal distension, it makes no sense at all, right? You can be very clear that no history suggestive of any distant metastasis like 1, 2, 3, 4. Now, hematuria, unless you're thinking of something relating to this disease or some other disease which may be related to it, I would be asking you. So, why did you take history of hematuria?
uh,
You must be wondering that one is being absolutely cynical. I'm getting after you, but I'm just making it easier for you. For those who are listening, if you don't want to bleed in war, sweat in peace. So it is a good time to be sweating. So what is the cause? Why are you taking this history?
sir, in case of sir, in trauma to sir, external genitalia, there can be hematuria, sir.
No, no,
That's
no,
all
no.
you're
Or
thinking about.
No,
I've got
why
one
that
more
could be
question
problem?
which will happen later on. No history of injury to the scrotum. Now you're
yes, sir.
already what has happened? You've already got a frame and you're going to stuff the picture into it. It should be the other way around. You should have a frame made according to your picture rather than you're ready with a frame. These are the causes, this is the etiology, I must fit this into it somehow. And my diagnosis is already carcinoma male breast. So let's look for a testicular injury with then patient having hypofunctioning of testes, estrogen rising, carcinoma happening. Look, this is far fetched. I mean, it doesn't speak of a very intelligent history. Hemophilia could be related to, you were given a hint also, something to do with prostate. And there is an association between the two. Cancers can be understood. With therapy, it can happen. So the association may happen. Otherwise, you're generally taking this history for the sake of it. No history of headache, loss of consciousness, vomiting, features of cranial nerve palsy, or limb weakness. You're possibly trying to look for a metastatic history. When you say metastatic history, so you can clearly say relating to liver, lungs, brain, or bones. Rather than, I'm aware of some examiners who will still ask you questions because you can't choose your examiners, but at least you should know why you asked this question. And don't write no history of this, then no history of that, and no history of, there is no history of nipple discharge, contralateral breast swelling or axillary swelling, loss of weight or appetite, chest pain, cough, or distant features of distant metastasis. I think you don't have an answer for your hematuria, so don't put it there. And you've gone so far to connect it to injury to external genitalia, and the patient can forget that. Can you believe it? If there is an injury to genitalia, that's the first thing he's going to tell you. Okay, next slide. Now here, no history of any trauma to right breast or scrotum. Now anybody is going to naturally be alarmed. Why scrotum? Right breast, I can still understand. If there's no history of trauma, there's no history of trauma anywhere. And why scrotum? You must have some other reason. So I must ask you.
Yes.
Sir, again, this is testicular injury and
So what?
So
How related to breast in the
now
male?
this is exactly what I was calling as stuffing the picture, round picture into a square syndrome. So you have a square frame, the picture is round, now you're stuffing it inside. That is not how you should approach it. Speak what is present and take history which is relevant to your case. That is called an intelligent history. Okay. Now, no history of radiation exposure makes sense. Now, why history of steroid intake?
sir, again, sir, long-term steroid intake may lead to gynecomastia.
Now, again, far-fetched. So this all gets covered into no history suggestive of hyperestrogenemia or related scenarios, which could include many things: cirrhosis of liver, patient on therapy. Steroid is just one part of it. I'm not denying that part. You're justified in asking. But I can see that you've looked at the, the list of causes and you're trying to take history of everything. It may not be fitting in nicely. Okay. Now, when you say no past surgical history, which surgical history you were looking for specifically?
Sir, orchiectomy, sir.
Okay. And please move out of that groin area. Something else. Again, I mean, you never know if the patient underwent surgery for prostate or cancers related to prostate or any other site which you have taken in your family history, the history of BRCA related cancers. Besides that, there are other conditions also which contribute, but we'll come to that when you move to that slide. Next slide, please. Now, mixed diet, married, 2 children. How is that useful for you? 2 children.
Sir, actually, that is also sir, not that. So say sexually active. That what's.
Is there any connection between the two? You see, the only thing we
In
know.
male breast cancer, do you think there is a correlation in male breast cancer? Do you think there is any correlation between number of female and cancer?
It's a hypogonadism or relation with some other diseases may cause azoospermia and all those
Okay.
things
Now
may be
listen.
related to client fetus.
Listen. What Dr. Shah was trying to take you for is relevance is more important for us. Everything can be connected. You can join the dots. But when you're looking at, this history, you are comparing it or somehow bringing in its counterpart in the female's obstetrics history. So I must ask something from the male also. It may not make a lot of sense here, right? In females, of course, there is a connection between the early pregnancy, number of, you know that. So I think you probably are running out of ideas when you take all sorts of histories. Hypogonadism is an idea which you can probably highlight. I have nothing against that. But okay, next slide. We'll save on time so that we can discuss something more. Next. No history of BRCA1, BRCA related. No. Please go back. It's not over. Please go back. Yes. Now, that's not the only thing you would be asking. You would look for family history amongst females as well as males, right, which you probably covered up, and also some syndromic illness in the family, because you're looking at other genes also. It's not just BRCA, it's a P10 and other genes also come handy. They also contribute in some way or the other. So I've touched upon some points, and all I was trying to look at was that laundry list that you're trying to prepare straight out of the book may not contribute significantly. I mean, it may not give a good impression. So therefore, don't put unnecessary stuff there. Make it very precise and simple. You don't have to have a complicated history every time. In a male breast cancer patient, must be having just confined history. And in any case, everything is negative. You see? So that's my advice to you. Next slide. The summary is okay. We can move to examination.
Patient is examined in a well-lit room with informed consent. Patient is conscious, alert, cooperative, well-oriented to time, place, and person. Performance score is 90 by Karnofsky performance scale. A patient is of average build and preserved nutrition, no dehydration, and decubitus of choice. The pulse rate is 80 per minute, regular, normal volume, no radial or radiofemoral delay. BP is 180 per minute on supine position. Respiratory rate is regular, abdominal thoracic. There is no pallor, icterus, clubbing, sinus, or edema present. And there is no generalized lymph nodopathy. And examination of breast. Patients examined in sitting supine and semi-recumbent position with arms on side, raised and pressing against the hip. On examination of left breast, it is normal. On inspection of right breast, right breast examination, on inspection, right breast fullness is noted. No visible dilated veins of body orange or nodules present. On raising both arms, is dimpling in right breast noted. A small ulcer of 1 1 into 2 centimeter on the superlateral side involving the right nippulateral complex partially with irregular margins, everted edges, with slough and necrotic materials in its floor, with active serous discharge. Although the nipple areolar anatomy is distorted, but no nipple discharge is noted. On palpation, all my inspectory findings are confirmed on palpation. No local regional rise of temperature. There is no tenderness. A lump of 4 into 4 centimeter measured in its greatest dimension is palpable in central and upper outer quadrant. It's non-tender, irregular surface, ill-defined margin, and hard in consistency. Skin over the lump is not non-pinchable. A lump is not fixed to the underlying structures. No nipple discharge on pressing the lump. The ulcer is 1 into 2 centimeter over the lump involving the right nippulateral complex partially. It's non-tender with irregular everted margins, floor covered with slough and necrotic tissue, and with active serous discharge. On examination of axilla, on inspection, there is no visible fullness noted. On palpation, left side no palpable lymph node, right side 1 into 1 centimeter non-tender, hard, mobile lymph node is present. On examination of supraclavicular region, no visible fullness or palpable lymph node. On examination of external genitalia, it is normal. On parectal examination is normal, and on spinal examination there is no paraspinal tenderness. Systemic examination is essentially normal. Summary of my case: a 60-year-old gentleman with insidious onset, rapidly growing lump in his right breast for last 4 months, initially 1 into 1 centimeter to presently 4 into 4 centimeter size, with an ulcer over the lump involving right nippulateral complex, with a mild dull-aching intermittent pain for 1 month without any history suggestive of distant metastasis. On examination, a 4 into 4 centimeter non-tender hard lump over the central and upper outer quadrant with irregular surface, ill-defined margin, dipping or raising the arms, and then 1 into 2 centimeter ulcer over the lump with distorted right nippulateral complex and a palpable lymph node noted in right axilla.
You can start with the first slide. We're not interested in diagnosis. Examination first slide, please. We just revisit it so that we can make a correction.
Yeah.
Your journal examination is perfectly fine. I mean, 100 out of 100 there.
One thing, sir. 90 Karnowski is minor symptoms and signs of the disease. So if you say patient has got
I was
lump,
waiting for Dr. Saar to point it out. It is
which is
every time whenever we are examining together, we
yeah.
hear this. What is 90?
So, it should be at least 80. The
No,
patient has
I'm asking
major
you,
symptoms and signs of the disease.
how can it be, with this kind of a picture, 90s? I think you are 90. You are not symptom free. Nobody is. It's very difficult to be 100, right?
Major symptoms and signs of the disease should be 80. Major symptoms.
Now, what is
Okay.
decubitus of choice?
It's a patient.
See, it is unnecessary. Don't waste time. Decubitus of choice would be relevant in patients with where it is changed. If a person is sitting and talking to you right now, he is obviously in a state of his liking. Decubitus choice, the concept came in with, say, fixed flexion deformity. How is he going to lie down? He's got acute abdomen. How is he going to lie down?
Yeah.
He's got Burgess disease. How is he going to hang his limbs or lift it up? So basically, this concept of decubitus was to just highlight that patient is lying in that position. Was there anything special about his position? No.
No, sir.
So I'm just asking for my curiosity. Preserved nutrition would mean that you have done examination of the nutrition the correct classical way. What did you find? What made you feel that its nutrition is preserved?
Sir,
What about
by checking
general
for the
appearance? Anything in the general appearance, you can say yes, he looks poor nourished. Anything in general appearance?
muscle bulk and
Muscle bulk,
medium
the face,
circumference.
malar prominence.
So
Mid-
actually,
mid-
Dr. Shah, they make it a little complex for themselves, and it's got partly to do with the examiners also. They skip over this. It's a very casual statement, friend. I can help you. You can have a journal look as Dr. Shah is saying, but between you and Dr. Shah, there would be a big difference because his eyes will see what will take another 50 years to see. So it is therefore a subjective appeal. So one is appearance, very correct. But then you're very specific and it doesn't take more than a minute. So you have the three major components, that is carbohydrates, proteins, fats, micro and macronutrients.
Yes.
Okay. So for the carbohydrates or calories, you have BMI, which you can mention, and there should be no hesitation. For proteins, you have the mid-arm circumference. Don't say basal bulk. You may measure it. No harm.
Yes.
For the fats, you measure the triceps fold thickness. You can measure it. You must have vernier caliper in your kit. For the proteins, you've done it. For fats, you've done. Carbohydrates, you've done. Proteins also look for edema, anemia, and it is very common. You will say pallid is positive, patient has got preserved nutrition. That's a contradictory statement. You may have a BMI which is normal, but the patient is malnourished because it could be anemia itself, which can be a factor. Then macro and micronutrients, ask the patient to stick out the tongue. A bald tongue would mean a geographic tongue, which is vitamin B12 deficiency, beta spots in the eye, cholinergia, finished. It doesn't take more than a minute. But to always test, you may run into an examiner who's interested to know. Sometimes the examination happens only for this. So basically, don't just call it preserved nutrition because you think he's fine. Because I may say you are not fine because then your reference point is wrong. Therefore, always have an objective assessment when you're doing examination. Otherwise, you can say patient looks good, he's happy, cheerful. So be careful about using this term. So usually what I would teach my students is nutrition is preserved on account of BMI being this much, at least some reference point,
Yeah.
which is
Okay.
anthropometric
Okay.
assessment. So you just can't be casual about it. Okay. And dehydration status and other things are preserved. And like very correctly pointed out, 90 Karnofsky is very, very minor illness, very, very minor. 80 is safer. Okay, let's go. Next slide. Now, see, most of us won't be interested in this part, except for the generalized lymphadenopathy.
Yes.
And you will be asked a question about it, which I'm sure you would be happy to answer. What is it?
Yes. Sir, this regional lymphadenopathy, I mean, two or more than two non-contagious lymph.
No, you're not answered that. I just took a chance by asking. This is an undergraduate question. What is generalized lymphadenopathy?
Sir, two or more than two non-contagious regional lymph node enlargements.
So when you're answering it, I know you understand, but you should be able to put it across to the examiner. Two or more than two non-contiguous lymph node basins or regions, you can say. Okay.
Yes.
When they are
Yes.
involved, you call that as generalized lymphadenopathy. Let's move. Now you mentioned that I examined in sitting supine. It's a good idea, but don't go out of the world because in ladies, it makes a big difference. In this patient, lying supine, tilting, bending, everything is going to be just one. So don't complicate it. Although I understand we understand your intention, we understand your emotions, but it should be relevant to this case. So don't make it complicated. Now, when you
Because in
take
male
this,
patient, it won't make a change.
it
In
won't be
female
changed
patient,
much.
pendulous brace makes a change, but in male patient, it don't make a change if
Yeah.
they recombinant and sitting.
Yeah. Now, what did you observe on pressing against the hips?
So pressing against the hips, the pectoralis major muscle
So it is
get
not
counted.
required, sir. It's a part of test or the science which you try to use for picking up the fixity to deeper structures. So
Yes.
it is not, I mean, all right, even if you want to be obsessed with it, male breast cancer is so rare that you wouldn't get it, maybe, but if there is a case, it'll be kept. The patient is examined now. And for the benefit of all students, always mention in past tense because you've already done it. The patient was examined in sitting supine, semi-recumbent, with arms on the side, say raised, pressing against the hips. Arms by the side and raised is fine. Pressing against it. I have no problem with that. I'm just making it better. Like I told you, there'll be some finer points that you would feel like we're splitting the hair. But for your own good, you should understand logically, does it make any sense? Okay. Now, what is this LEFT?
Sir, left breast and right breast.
So you start with that. Left breast is normal. Finished. The
Yes.
left breast and axilla are normal. Finished. It's over. And although I have nothing against it, describing it into inspection, palpation, percussion, but like I observed in axilla, you mentioned on inspection, no fullness seen, but on palpation, there is a node. Nobody is waiting to hear that. There is a axillary lymphadenopathy. This is the lymph node. Describe that, and that's what you want to know. Okay.
And I think, sir,
Okay,
in a male breast, sir, in a male breast, if it is a 4 centimeter lump, the lump should be visible and he should be able to describe because in
That's what I'm saying.
inspection,
Unnecessarily is
we can
getting into
fully.
trouble, and he has described it. See, if you look at it, on inspection, he doesn't want to talk about it, but on palpation, he's going gaga over it.
Yes,
You see,
yes.
that's what happens when they try to divide it.
Yeah.
And Dr. Saha has made a very pertinent point. In a male breast, do you think it was a normal looking breast?
no, sir.
So then how can you say, oh, no, you mentioned, right? Breast fullness
This
noted.
fullness.
No visible dilated veins or podiorange or nodules present on raising both arms. Dimpling in right breast noted. Be very careful. Dimpling is usually seen when the ligaments of Cooper have
Cooper's.
that length available. In this case, it will be more or less fixed. It is very
And
difficult.
ulcerated, already ulcerated.
And when you got an ulceration, how is this dimpling going to help? What is dimpling?
So dimpling when the ligament of Cooper is infiltrated with malignant cells, then
How
there is
does it
dimpling.
help you, even if you find out? You see,
So
this
fix it.
concept is very confusing to all students. Dimpling has got nothing to do with skin.
Yes,
It
sir.
has got to do with the ligament of Cooper, which is connecting the skin with the pectoral fascia. So those days when there was no screening modality available, this was one way of screening for it. You'll ask the patient to lift up the arm, and if the lump was not visible, you still would find based on dimple that this patient could be having breast cancer. When there is a visible lump with ulceration, it is going to make no difference at all. And I don't think it is present. What you're calling dimpling is not dimpling because maybe since you have not shown the picture. For dimpling, you need a breast and some area where it can get depressed in a nice way. And dimple is a very smooth depression in
Yeah.
this in the in the skin that you observe. It's like you're pulling some cloth with a string attached to it. So when you pull it, it tends down nicely. That dimple is a good sign. I don't have it, but those who have it, dimple is taken as a good sign. This is not dimpling. Therefore, one, it was unnecessary, and two, you may be wrong. Then on raising both the arms, this is unnecessary and extra. That may be because you're not presenting that frequently. It'll get corrected today. Then you have an ulcer. Now, I personally think it would have been easier if you would have clubbed the two findings, but I stick with, I mean, I'm okay if you do want to do inspection and then palpation. I'm trying to visualize your case because even one picture would have helped. A small ulcer, 1 into 2 centimeter, superior lateral surface, side. Now, we normally describe breast anatomy when you're doing examination, either in the form of regions or quadrants, some people call them,
Quadrants.
or the clockwise. Otherwise, we can't visualize what you're saying. You're saying superior lateral surface, and then you're saying nipple. I know it's a small breast, so it's more or less the whole breast. Okay, so to be able to very clearly demarcate superior lateral would be a challenge. Now, a small ulcer, you described it, and then you describe it again. Go further. I'll show you that you're describing it again.
It's unnecessary for the palpation.
So
Palpation.
no. Can you go back, please? All my inspectory findings are confirmed on palpation. Which inspectory finding needed confirmation? Temperature, no local rise of temperature. Where did you look for temperature rise? In the skin, no? Not on the ulcer, naturally. No tenderness. You don't have to write. I mean, there is nothing there which you needed to confirm. There was a lump. Do you know how big is 4 centimeter? Huge. What would be the usual size of a male breast? It won't be that large. And as correctly pointed out, it would be all visible. It will be very clearly visible. It's a big enough lump, palpable in central and upper outer quadrant, central region it is called. So I think it's more or less the whole breast. Is there any part of breast which is not involved?
It should be whole breast.
Yes.
So it becomes easier for you. And then it's a ulcer overlying the lump or ulcer is separate from the lump.
It's overlying.
So that makes it very simple. So there is a lump which is got the skin involvement and ulceration on the surface is visible. So it gets very simple now. They don't have to get mixed up. Lump is not fixed to underlying structures. This is where you don't have to say placing hands on the hip. Then you would be asked, what is the underlying structure to your lump?
So the pectoral fossa and the muscles, the pectoralis major
So,
muscle.
sir, it is better to say clearly it is muscle or the chest wall. Is it fixed to muscle or the chest wall?
Sir, if it is not mobile, then it's fixed to chest wall.
No, no,
If
no.
after
Your
pressing,
case, your case, your patient.
It's mobile, he said.
Sir,
No,
yes.
no fixity.
Not
So
fixed.
no
No?
fix, no, not
So
fixed.
it is free from
The
muscles.
deeper
First you're
structures.
describing the muscle. How did you test for that?
For sir, for pectoralis major muscle, at first before checking for the pectoralis major muscle, we have to check that lump is fixed to the chest wall or not. If it is mobile, if it is not mobile, then it is fixed to the chest wall. And after that, before pressing the hand, putting the patient's hand on over the hips, we first check the mobility along the fibers of the pectoral muscle and perpendicular to it. Then after pressing, I'll ask the patient to press the
Yes.
both the hands over her
Okay,
hips, over
so
his hips.
since you're taking long, we examine all fixity to any deeper muscle by going through 3 steps. Number 1, examine when the muscle is relaxed in both the axes. Number 2, make the muscle taut and confirm that it is taut. And then
Yes.
third, repeat step 1. So it's as simple as that. Now, suppose you're saying it is fixed to begin with. Does it mean it is fixed to chest wall? Always. What is chest wall? Is pectoralis major a part of chest wall? Am I audible?
Yes, yes.
Yeah, yeah.
Yes.
Don't look
What
for
is chest
answer
wall?
anywhere else. You won't find it.
What is
Just
chest wall?
Yes.
If you say it's fixed to
what
chest wall,
does
means what?
chest wall mean? You know or you don't know? If you don't know, say you don't
Sir,
know. So don't waste
sir,
time.
I don't know.
Chest wall is ribs, intercostal muscle, serratus anterior. Can you
Yes.
repeat that?
Yes, sir. Ribs, intercostal muscles, and serratus anterior.
So
Intercostal muscles.
pectoralis major is not going to be important for staging. It doesn't change anything. The only thing it does is it can make us know whether we need to remove it along with the specimen or not. Otherwise, it has no meaning. Okay. Now, also when the whole breast is involved, be careful that it could be fixed to chest wall to serratus, while it may not be fixed to pec major. Not in the male patient. I'm generally telling you. So you should be clear on that. So don't say to underlying structures and then we imagine whatever. But I agree with you. If it is not even fixed to pectoralis major, it's obviously not fixed to chest wall. So it doesn't make sense to test for it. But suppose you were asked to test for it, how would you test for it? Okay, I'll give you a situation. I'm trying to make a case out of you. I know you're waiting to discuss the TNM staging and then its management and the role of PET scan, etc. That is secondary and not very important. This is the clinical class. So how would you differentiate between a lump which is fixed to begin with, but you don't know whether it's fixed to pec major or also to the chest wall?
So on touting the pec measure, if the mass is not
It's
mobile,
already fixed. When you mentioned that point, if it is fixed to begin with, that's why I'm asking question. Otherwise, I
Yes.
wouldn't have asked you because I'm not a great fan of that test. But since you mentioned that if it was fixed to begin with, I won't do the test. So I'm asking you. I say it is fixed to pec major only, and it is fixed. So we do forward bending test. If it goes down with bending, it is just the muscle. If it doesn't go down, it is the chest wall. Right? Very, very poor test, but your answer should be there in the exam. I'm covering for other students also. In a female patient, in a lady, it could make sense. Okay. In a male, one would be very surprised by the description you have given. This patient is extremely lucky that it is not fixed to anything deeper. While it is ulcerated, it has gone outwards, but it's not gone inside. That's what It's not commonly seen. That's okay. Now you're saying skin over the lump is not pinchable. Now, who is interested in it now? It makes no sense to me. If there is ulceration, what does it mean? What are the
Already skin
components of
involved.
skin involvement?
So ulceration, satellite nodules, and pure orange.
Yes.
So you have ulceration. Yes. If you have ulceration, how does it make sense now to pinch it? How will you pinch the skin? Nobody can pinch it. Male breast, pinching the skin in an ulcerated breast. I can visualize the case. Half the findings are wrong, sir. You're just making them into it. If you're shown, maybe it would change. No nipple discharge on pressing the lump. There is no nipple left. You've already mentioned the areola is all destroyed.
It's a partial.
So how would it
But still,
discharge
it's
now?
not necessary. Already nipple is destroyed
Is
and
it a
ulcer
common
involved, and
common
still there is a
finding to
sterile
have
discharge.
nipple discharge in male breasts? What does it discharge? You may rarely have bloody discharge in completely innocuous cancers, which are not yet manifesting as lumps. There is a possibility of bloody discharge, but otherwise, in a case like this, it makes no sense at all. Next slide. I'm so happy you did not purpose for Intel memory notes. I was waiting that you do that, and I'll tell others because it's a common thing to say, I have to look for the Intel memory notes, and the most hopeless test to do. And invariably, such non-specific tests, such non-sensitive tests, you will not pick up anything. Ulcer is 1 into 2 centimeter over the lump involving the right NAC partially is non-tender and irregular everted margins. How do you evert a margin? Margin is a line.
What is that described as age?
Is that the margin
Age.
which will get everted?
Age.
So be careful because this is a silly mistake. You've already mentioned everted edges before, which was all right. But here you mentioned everted margins because a lot of you do this mistake. That's why I was highlighting it. I'm not enjoying picking up your problems. I'm trying to fix your problems. Can you fix a problem without picking it? You can't. The best way to not fix anything is not to pick it up. So don't get into that trap. Floor covered with slough and necrotic tissue with active serous discharge. Now, what is an active serous discharge?
So the serous discharge was present when I was examining the patient.
That's enough. What do you mean by active serous discharge? So you use the term which is not your term. Don't borrow problems.
That should be continuously playing them.
Yeah. Next slide.
Yeah.
Now, axilla on inspection. Who is interested in your inspection now? Inspection is over long back. And you then mention on left, no palpable node. You already mentioned no left breast and axilla normal. So that's the end of the story. No, don't waste your time. Don't waste your examiner's time. And don't irritate him. That is what should be done. On palpation, I mean, can you ever inspect a lymph node in the axilla? So my stage would be axilla. There is a 1 into 1 centimeter non-tender hard mobile lymph node. Finished. The rest of the statements are all useless. They have no relevance. And there is no supraclavicular lymph node. Who's interested in you said no visible fullness or palpable lymph node. The fullness is a harbinger or an indicator for lymph node. When you didn't find the node only, you can't say there's not even sign of that thing. That thing is not there and the sign is also not there. Obviously, the thing is not there. How will the sign be there? Are you understanding, friend?
Yes, sir. Yes, sir. Yes, sir.
You getting what I'm speaking or it
Yes,
is
sir.
hard? So
No, sir.
there is no supraclavicular lymphadenopathy. There's no supraclavicular lymph node. Okay. And if you were even better than that, you would be, what is the present day definition of this node, which is related to breast cancer? Is it the same that you find supraclavicular fossa is big? To read about it. They've described it with the AJCC 8th edition. So it may not always be. That is how N3 became still a treatable case. Earlier it used to be M1. N3, the node in the supraclavicular fossa used to be M1 earlier. Now it is not, you know that. Next slide. Now comes your external genitalia, which is in capitals, because this is where you are spending all your time. External genitalia, yes, can be a very minor contributor to the whole story of testes, not one, both getting hurt. Not only getting hurt, getting rogered, leading to no testosterone or low testosterone, leading to high estrogen scenario for a long time, leading to development of gynecomastia, which is contributing to cancer of the breast in some minority cases. Can you believe how far you've gone? But external genitalia are important to examine. Nothing, I'm not saying they are not important, but you have given it so much of importance in your presentation throughout that I wanted to highlight. And when you say DRE is NAD, you will be asked a question, why did you want to do a DR?
To CNA abdominal metastasis, Bloomer self,
Oh, Bloomer shelf, yes.
and the prostatic for
Yes,
check the
now
prostate.
you're making some sense. So, since male breast cancer is usually seen in elderly, they may have a coexisting cancer.
Yes.
That is one. Number two, they may have Bloomer shelf. And number three, you must mention, I would take consent for it. If the patient says, I don't want it to be done, it is not a mandatory part of your examination. Right? We'll come to
Yes.
that part. And when you're saying spine, no paraspinal tenderness. But is there any spinal tenderness? Sir, spinal examination is normal. Why are you buying problems?
Yeah. Paraspinal is
Examination of
muscle.
spine includes so many things, not just
Paraspinal is mainly
tenderness.
muscle. Yeah.
Okay? You will
Because
examine for the deformity, the intervertebral space being challenged. Paraspinal tenderness is one part of the problem. Just the examination of the spine is normal. It's a site of metastasis. So you look for, they could just be presenting as kyphosis, a gib bus. You know, the causes of kyphosis include Cox crush cancer and Kummel's disease, all 4 Ks, cancer with K. So you can have a metastatic presentation there. But then paraspinal tenderness is a very, I mean, even you may have paraspinal tenderness if I examine you the correct way. Because sitting in a posture, you may have tenderness. So therefore, unnecessary, you know. You can say examination of the spine is normal. Next slide.
okay, sir.
Now, this you fortunately covered very quickly. You mentioned that GCS is 15 by 15, and we are so grateful. If his GCS was not 15 by 15, would he be giving you all this history? Hello?
No, sir.
So, examination of central nervous system in a patient with breast cancer is to look for any effect of metastasis, or he has no such history. So, don't go that extra yard unnecessarily. They are all normal. Okay? So, you can skip that part. All right. I know you
Okay,
can
sir.
never forget to mention S1, S2 is normal because they all are obsessed with it. So that you cannot possibly change because this is a spinal problem. It's Pavlovian. When you're describing it CVS, S1, S2 normal, apex beat in the fifth intercostal space, left side in the mid-clavicle line, all that stuff is no surgeon would be interested in it. We're looking at a very specific problem. Let's move.
Next, diagnosis. Come to
Now, you've
diagnosis.
given us a beautiful summary and you give us the diagnosis. Is it a surprise to us now?
It's a 60-year-old gentleman with locally advanced carcinoma of breast with right axillary lymphadenopathy without features of any distant metastasis, clinically T4B and 1M0.
Good.
Right, good. And please make it a point to qualify at this point. Tell every student to do the same. I'm telling all of them that, you know, the Eighth edition has brought it couple of changes. One is, of course, about the satellite nodule. You must have intervening skin, which is normal. Second is about ultrasound assessment or staging is not done clinically anymore. It has to be with ultrasound. You can always mention that. And of course, LCIS has disappeared as a cancer. Those are other things. But importantly for your clinical examination, so what would you say? 60-year gentleman with carcinoma of the right breast, with right axillary lymphadenopathy, with no clinical features of distant metastasis. That and my clinical stage is CT4B N1, which I would like to confirm on ultrasound M0. Okay. Now, what this ultrasound has done, your clinical examination for internal memory is not required. You will pick it up only on ultrasound, and it doesn't make a difference in your planning or the management. And then you'll mention a case of, therefore, a locally advanced breast carcinoma. Is that okay?
Yes.
Now, there comes your part. I won't ask you why is it carcinoma of the breast, but tell me why is it locally advanced?
So because it already involved the skin, so locally advanced carcinoma.
So define locally advanced breast carcinoma.
Locally advanced breast carcinomas are the subset of breast carcinoma in which the tumor may be more than equal to 5 centimeter with or without regional lymphadenopathy. And there may be regional lymphadenopathy with
So
any
you
tumor
are
size.
going to take a lot of time from your examiner. He may be impatient. He may have to examine a lot of candidates that day. Can you be more brief?
Stage 3 ABC, sir.
That's it. So why were you holding back? Would have answered it straight away, and you then would have scored more marks. So don't waste time. Or in terms of no, he'll say, tell me in terms of T and M. Okay, T4 with any N and M0,
Yes.
N2 with any T and M0, and some people take T3, which is more than 5 centimeter, N0, M0 also as locally advanced. And some people take it as large operable or LOBC.
LOBC.
Again, most people in the West would treat as locally advanced breast cancer, right? How do you proceed now?
So I'll do some tests to confirm and support my diagnosis, and then stage the disease, and then do some tests for proceeding to further management. For confirming and supporting my diagnosis, I'll go for triple assessment, which consists of clinical examination history, which I have already been covered, and then I'll go for radiological assessment, and then I'll go for histopathological assessment of the specimen.
What radiology?
For radiological, I'll preferably go for sonomammograms, because mammography will give me the picture.
How difficult is it to do mammography in such a breast?
It's difficult because there is no breast tissue.
So then how would you do it? So don't just repeat what is written in the book. Now, you will say mammography if it is feasible. A lot of people recommend that you can do it, but you can't compress a breast like this. There's ulcer, it'll be painful, and there's no information available because the breast is, I mean, I have not seen the picture, but it is not going to be some breast which you can put in a
Almost the whole breast is involved, yes.
Yeah, ultrasound is good enough.
Ultrasound. Yeah.
And what else?
And
So do ultrasound of the breast and the axilla, which in any case you have to do.
yes, sir.
And what would you do for the staging?
And so for staging.
Sorry. You were saying about the histological.
Histopathology.
Okay. What do you do for that?
We'll go for ultrasound guided true cut biopsies.
Now there is an ulcer. Why can't you take an H biopsy? You don't know? Good. When you don't know, say quickly, I don't know, because it's easier. See, there are two problems with that. One is it could be giving you an equivocal diagnosis. If you're lucky, you get a diagnosis. And if you have an underlying lump, the answer is image-guided core biopsy. You will find a lot of necrotic material in the ulcer, as you have described also.
Yes.
And it is always better to go for the core. Now, although it is not wrong to do edge biopsy, so you should be open to both. But you may get equivocal diagnosis with the infection and contamination there, and a lot of necrosis there. And this necrosis is not, it's a cancer necrosis. So it's all necrotic material, which is absolutely, this got no supply. So,
Yes.
and you got a patient who's got a active serous discharge. So it is expected that it is seropurulent rather than serous. Pure serous is unlikely in an open wound, right? It will get contaminated also. So therefore, image guided core biopsy. Image will take
Yes.
you to the place which is most representative. What other investigation is necessary for image for staging?
Uh, for staging the disease, I'll go for CT chest, abdomen, and pelvis, and I'll go for biochemical examination, doing the LFT, checking if the ALP is raised. Then I'll go for bone scans.
No, actually, you don't go for bone scan based on the heat labile ALP, which is done in
Yes.
doubtful cases of early breast cancer. Here, it's mandatory to go for the purely metastatic workup. You need CT, thorax, abdomen, and pelvis, and
Yes.
bone scan. It is a
Yeah.
part of your protocol. And PET scan is also recommended by a lot of people now as a good one investigation, which is less expensive when you add up all the investigations. And they are able to combine PET CT if the patient can afford it, if the facility is existing. But if it is not existing, then you possibly can go for it. When you based on the LFT, when you are planning it, it's in a early breast cancer when the patient is symptomatic or you're doubtful or it's borderline, but it doesn't change your approach. But something changes. What what is better for bone scan? Is it which isotope for PET scan? Uh, if you know about it, then I'll
No,
dwell.
sir.
Otherwise,
No, sir.
for a postgraduate, I'm happy. So you can do,
No,
these
sir.
are your options. What do you do? Why CT abdomen?
To look for any.
Yeah, so you're looking for metastasis.
Yes.
What is the problem with PET scan in this patient or in our patients? Why? False positive, no? Lots of false
Yes.
positives because of tuberculosis and other underlying infections.
Inflammatory lesions.
Yeah, so you can pick up too many artifacts and you may then upstage the disease. Then your treatment may, I mean, they are very close to becoming metastatic anyway. So it can be a challenge. So that is why some people don't like PET scan at all. And most of the time, PET scan is not available. Now, if I may ask you, what are the situations where PET scan is beneficial?
Sir, if you- in a will anyway we'll go for some multidisciplinary team meeting, and in that case, if we plan for NACT or on a post-operative and post NACT prognosis, and that we can follow up, we can
Excellent.
check up
So
that.
your answer could be that usually when you're going to use PET RACIST criteria for assessing response, it's where you can look at the anatomical response as well as biological response. Uh, and also in situations, as I mentioned, where all three can be replaced by one test. That is where the people feel that it should be done. In LABC, there is a category 2B recommendation, so you can actually get PET scan done. Most of us get CT, thorax, abdominal, and pelvis. PET scan patient may bring with him. That is what happens in our setup. So let's move further. What do you do to manage this case now? Suppose your stage is correct.
For management, first we'll go for and multidisciplinary team meeting, and I will plan with the in the multidisciplinary team that the patient should get NACT or not. After getting NACT, we'll go for surgery, and then
So what is
we'll
the
go for
advantage of
adjuvant.
neoadjuvant chemotherapy in this patient?
Sir, it will the advantages are it will downsize the
So what?
tumor.
So what will be the downsizing here? It's this skin is already ulcerated. The skin won't come
And
back.
will it will take care also of the
No, beta, don't
micrometastasis
do that
also.
common mistake. repeating it like a parrot, which is what a lot of people do. Yes, neoadjuvant chemotherapy is beneficial in downsizing, downstaging, taking care of the micrometastasis, taking care of providing you the in vivo chemosensitivity test, right? And these are answers you provide in a situation where you are trying to plan breast conservation. The size is going to reduce. In a patient with a fungating mass or ulceration, it may still be decided because sequencing doesn't change the outcome. So there is a possibility. So don't be rigid on it. It will be discussed in MDT, and most of them would say, let's give a trial of neoadjuvant chemotherapy. What is the usual biology of these tumors? You did core biopsy,
Sir,
no?
yes. Sir, mostly ER positives.
ERPR positive and
Yes, sir.
HER2.
Negatives.
What do you think?
So they are luminal A types. Okay.
Luminal.
So neoadjuvant chemotherapy may not be very effective because neoadjuvant chemotherapy works best for ERPR negative tumors
Negative.
and Ki67 being less than more
14,
than
more than
14%.
14%.
So these tumors are not so aggressive usually. Usually, I'm saying. Anatomically, they look challenging, but biologically, they are not bad. So a lot of people may not like to put them on neoadjuvant chemotherapy if you can get a clear margin. So you should ask a question. If I think I can get a clear margin, I would rather resect and put the patient on adjuvant therapy. Although I told you that in MDT, a decision may be taken. And next time, don't call a 60-year-old gentleman elderly, please. The age has changed. Elderly is much older person. When you cannot give chemo, you cannot give, they are around 75 in our part, 80 plus in the West. Performance status is more important. So if the patient can withstand it, then only. Otherwise, you can make the treatment worse than the disease. Sometimes they may die of chemotherapy. They are very old people. So therefore, you can treat by upfront surgery. Also, be prepared for that. All right? Because
Yes, sir.
sequencing is not showing, that doesn't make any difference. The only advantage in this patient would be, or advantages, if I may say, that can take care of micrometastasis and you will get an
Yes.
in vivo chemosensitivity test.
Sensitivity.
I'm looking at my watch. We have just 2 minutes. So 1 minute I'll take and then I'll finish. I think you should be open to answering this. Sir, if we find we can get a clear margin, there is a possibility of treating it by surgery upfront and putting the patient based on the biomarker status on hormone therapy or chemotherapy, depends. Or in addition, radiotherapy based on your histopathology. Correct? Now, in ERPR tumors, what is it that they would prefer? They will all get radiation, all
Tam-
LABCs get radiation, so don't worry about
yes,
it.
sir.
LABC radiation
Tamoxifen.
contraindicated has to be given to all. So that part I'm not discussing to save time.
Sir, tamoxifen, sir.
Tamoxifen,
Tamoxifen.
but a lot of people agree on putting them on aromatase inhibitors also because they act better. But one treatment for 5 years is not what they recommend. You can provide them switch therapy. So you can have both the options. But yes, hormone therapy is also a good option in these patients. Okay. Now they will all get radiation anyway. So I'm summing it up. The answer is it will be discussed in the MDT and also with the patient.
Yes.
The patient says, I want to get surgery done first. You can't do neoadjuvant. Okay, so that's over. Your MDT also goes for a toss. If he says no, do my surgery, I'm over. That's one thing. First thing. Second, if the MDT decides to put the patient,
Except if the swelling is fixed to the chest wall, you say
no,
inoperable.
that's what I'm saying.
Then,
So
yeah.
if you cannot get, that's what I was saying. If it is non-resectable,
Yeah.
or if it is not possible to get a clear margin, I think that's what I said.
Yes, sir.
You have no advantage of putting these patients on neoadjuvant chemotherapy, which especially because they are ERPR positive tumors, right? ERPR positive tumors are slowly multiplying tumors, and chemotherapy doesn't do very well in them. With triple negative, the chemotherapy works very well, what we call as triple paradox. I'm not saying you won't put on chemotherapy. So this will be discussed in the MDT. But if you can get a clear margin, like chest wall fixation, you won't get a clear margin. And if it is extensive, you may have to reconstruct, but you can get a clear margin. So therefore, if it is resectable, you can resect and put the patient on adjuvant hormone therapy, which can be in the form of tamoxifen or aromatase inhibitors. Aromatase inhibitors have toxicity. What is it? Quickly.
It's a cardiotoxin. No, aromatase, that is um,
Yeah, that's the problem. This. No. That. Then A, B, C, D, and none of the above. That's how you're all trained. That's how you're
say
MCQ zombies. C, aromatase inhibitors, A, B, bones. They eat up the bones, right? Tamoxifen,
sir, thromboembolic.
T for thromboembolic, and endometrium, endometrial hyperplasia, then carcinoma. But this patient would not have endometrium. So tamoxifen is safe there. And there is bony deposition also. Tamoxifen deposits on the, in females, the problem is different because ovaries are not functioning. And it's all peripheral conversion, which is based on aromatase. So therefore, you need aromatase. But aromatase have been found to have a better, response in these patients. Okay, and all of them will get radiation. You can put patient on neoadjuvant chemotherapy like any LABC, but depends on whether it is resectable or not. Most of them are ERPR positive, but some can be negative. I operated on one recently, it was negative. So then the situation may change. So it will depend on your biomarker status. And if
Yes.
they're ERPR negative, HER2 positive also. Some people like to give neoadjuvant therapy with trastuzumab. So be prepared for it. Okay. But like, early breast cancer, when do you give neoadjuvant? When they're either triple negative or they're HER2 positive, HER2 enriched. So
Yes.
we can change our position, but we can tweak it. But if it is resectable, which means you can get an R0 resection,
Yes.
then you can do upfront surgery also because sequencing doesn't change the outcome. Do you have any question? Otherwise,
Yes, very comprehensive discussion.
right?
Thank
Sir,
you
may
very
I
much.
ask a question?
Please.
Yes, yes.
Sir, I have got a question in my exam that whether IHC is necessary for surgery. Because
Sorry?
if whether IHC is needed,
I can hear you.
Yes, it is needed, definitely.
whether
I,
IHC is needed before surgery if we are not planning for
mandatory,
neoadjuvant chemotherapy.
not needed, mandatory. Can you tell me why? I'll tell you. IHC means you are finding out the biomarker status, which is what we were discussing just now. So you will know it's a triple negative or ERPR positive cancer. Depending on that, you may plan neoadjuvant. So there is present a recommendation is the triple test or the triple assessment. It includes core biopsy for this reason. And don't call it TrueCut, please. TrueCut is a trade name. TrueCut needle is made by TrueCut. So it is core needle biopsy, CNB. So we do thorough history and clinical examination, followed by imaging, followed by core needle biopsy, because core biopsy will give you the biomarker status, invasiveness, and also the grade of the tumor. All three are required to plan therapy. Did you get your answer?
And more so, if the patient is unfit for chemotherapy, even hormone may be used as a neoadjuvant.
Now, if the patient is ERPR positive, in select cases, we may put the patient on hormone therapy. The only challenge is the response can only be assessed after 3 months. So we have to wait for 3 months before we say patient is responding or not responding.
Okay, sir.
Right?
Okay.
Happy?
Yes, sir.
Now, we have, can I make that announcement, Dr. Sai, if you permit? Dr. Sai is a part of our scrub course every year.
Yes, sir. Yes, sure.
And it is next month, I think 16th to 19th. All of you are welcome to be part of it. It's actually hybrid. We wanted to do it all physical, and Dr. Shah has been there since I started Scope in Delhi. And initially, when I conceived Scope, it was with Dr. Shah kind of people in mind. These are examiners or teachers who should be literally worshipped where they are. So they are all part of Scrubs. So please join in large numbers. You will find it beneficial. We already have a lot of people that have volunteered to present cases. It we'll also have physical cases for people to present there and then. But you can join virtually also if you can't travel, because this is something we have learned in COVID times, that virtual reach is much wider because we have students from West Indies, from US, from UK. Pakistan, Afghanistan, they're all joining. So you're
Yes, sir.
welcome. All of you are welcome to join. Dr. Shah, do I have your
Yes, sir.
permission?
Thank you very much. Fantastic coverage. We
Thank
have discussed basically mainly the clinical part, which is lacking. And you see, most of the time, people go with their fancy. We are not discussing fancy. We are discussing how it should go in the usual exam. That's it. Thank you, sir. Thank you very much. Thank you.
Thank you very much, sir.
Thank
You're
you.
most welcome.
Thank you, sir.
And mind you, you did well, Swaroop.
Yeah.
Keep it up.
Thank you, sir.
Thank you, sir. Thank you.
Good night, sir.
Good night, sir. Thank you.
Thank you, sir.
Thank you.